Good morning, ladies and gentlemen. Greetings from Stockholm, from European Center for Disease Prevention and Control. Welcome to our press conference. My name is Andrea Horvat-Kramaric. I'm head of communication and spokesperson and will be moderating this press conference today. Today, we mark European Antibiotic Awareness Day and the latest report on antimicrobial resistance and antimicrobial consumption. For that purpose, today with us, we have two speakers, ECDC Director Andrea Amon and Head of Antimicrobial Resistance and Healthcare-Associated Infectious, Dominique Monet. Both of our speakers will have a short introduction, after which I will open the floor for your questions. And just a few lines on house rules, even though I know you're well familiar with it. So when you ask questions, please introduce yourself and your outlet and the country you come from, and indicate, if possible, the speaker you want to receive answer from, and I will give you the floor. Just also to say, this press conference shall be recorded and placed on our YouTube channel afterwards. Without further ado, I would like to open this press conference and give the floor to our first speaker, Director Andrea Amon. Andrea, the floor is yours.
Thank you, Andrea, and also from my side, thank you for joining the launch event for the European Antibiotic Awareness Day 2022. Antimicrobial resistance represents one of the most significant public health challenges in Europe today. And despite all the work that we did for the COVID pandemic, we continue to work on AMR issues as a priority during the whole last 3 years. Now, we have renewed and updated our estimates throughout the European Union, Norway and Iceland on the burden of AMR. And the number now we found is that every year more than 35,000 people die from antimicrobial resistant infections, a figure that has increased in the recent years. And just to make it a bit more illustrative, this means that every day nearly 100 people die in the EU and Norway and Iceland. The burden of AMR in the EU remains similar to the burden of influenza, tuberculosis, and HIV/AIDS combined. And in addition, at around 70% of this burden is associated with healthcare-associated infections, which could be easily minimized through adequate infection prevention and control measures, as well as antibiotic stewardship in healthcare settings. Now, AMR is a silent and slow epidemic. It doesn't produce the waves and peaks that we have been seeing in the past years from the pandemic. And we continue to see high levels of AMR for several very important bacterial species, antimicrobial group combinations. And new ones continue to emerge. And I want to give you some examples. This is the case, for instance, for Acinetobacter species, a pathogen that is very difficult to eradicate once it established itself in a healthcare setting. In 2021, the number of reported Acinetobacter infections resistant to multiple antimicrobial groups, including carbapenems, more than doubled compared to 2018 and 2019. Another example of the current situation in healthcare settings is Klebsiella pneumoniae, infections that are resistant to carbapenems. There was a 30% increase of carbapenem resistance in 2020 and a further 20% increase in 2021. Now, why do I mention the carbapenem so explicitly? resistance to carbapenems is very serious because these antimicrobials are most commonly used to treat severe infections and usually reserved for multi-drug resistant infections. You can imagine resistance against such a drug will result that multi-drug resistant infections are less treatable. The last example I want to give you is Candida auris. It's a fungal pathogen that also causes outbreaks of invasive health care associated infections. And it can be resistant to multiple antifungal agents to be establishing itself in European healthcare settings. Now, the number of reported cases of Candida auris nearly doubled between 2020 and 2021, from 335 cases reported by 8 countries in 2020 to 655 cases reported by 13 countries in 2021. Now we have some, well, good news in the fact that our data show a decrease of 23% of the total antimicrobial consumption in humans in primary care and healthcare hospital sectors combined during the last 10 years. And that is a signal that we might be moving in the right direction. We should keep in mind, though, that there are possible factors that might be related to the last 3 years. So that measures that have been taken during the COVID-19 pandemic have influenced these figures in terms of healthcare seeking behavior, prescription behavior, and also occurrence of other respiratory tract infections, which we barely observed in the past 3 years. Now, nevertheless, it's an achievement. Despite this fact, we have seen excuse me, an increase in the proportion of broad spectrum antibiotics that were used, in particular in hospitals. And also looking at the past 10 years, the consumption of such broad spectrum antibiotics increased by 15%. Consumption of carbapenems, as mentioned earlier, by 34%. And the proportion of reserve antibiotics, which should be reserved for the treatment of confirmed or suspected multi-drug resistant infections, has more than doubled. So it's very obvious that we still need to strengthen our work in healthcare settings because AMR is a serious threat. And this is the reason why we also will continue in the coming years with our work. We will continue to provide data and evidence and recommendations so that evidence-based decisions can be taken at national but also at EU levels. As an example, in the next year, we will complete the 3rd point prevalence survey of healthcare-associated infections and antimicrobial use in acute care hospitals and long-term care facilities. We have also started, together with DG Santé, our One Health country visits for AMR. And we had done one country this year, and several countries are already interested for the next year. And from our experience, but also the experience of the countries, these visits are a unparalleled opportunity to really look in both sectors, veterinary and public health, at the gaps, what should still further improve, but also can highlight best practices. Because we have to keep in mind that, of course, the antimicrobial use in humans is not. that can drive antimicrobial resistance, the reservoir of AMR bacteria in animals also can play a role. To this end, we will continue what we have already been doing for some years with the European Food Safety Agency and the European Medicine Agency to produce an analysis of antimicrobial resistance and antimicrobial consumptions in humans and animals together. This is the biggest area for which such an analysis exists in the world. We also will continue to collaborate with the Environment Agency to see how we can enhance the environmental component for the One Health approach. So we have made good progress in the past years, but as I just mentioned, new AMR threats are emerging globally and in the EU, and particularly in healthcare settings. So we cannot stop doing anything. So we mustn't lower our guard. And we need to particularly do 5 things. First, we need to be vigilant and ensure that our surveillance detects the emerging resistance. We have to improve infection prevention control practices, in particular in hospitals and other healthcare settings. And we should continue to enforce some lessons that we learned during the COVID pandemic in terms of adequate hand hygiene, respiratory etiquette, vaccination, and if situations require also physical distancing or mask use. Fourth, we should continue our efforts to reduce unnecessary use of antimicrobials, and that is something that everybody of us should be doing. And lastly, we have to ensure that the implementation of the national action plans have a high-level support and robust funding, because only together we can ensure that antibiotics will remain effective. Thank you.
Thank you, Andrea, for this intervention. And now we go to Dominique Monet, Head of Antimicrobial Resistance and Healthcare-Associated Infections. Dominique, the floor is.
Thank you, and good morning. So the goal of this short introduction is to review the various ECDC outputs that will be published today. So first, we will be publishing a new report with an update of the estimate of the burden of antimicrobial resistance, or more precisely, the health burden of infections with antibiotic-resistant bacteria in the EU. ECDC estimates that in 2020 in the EU, Iceland and Norway, there were more than 800,000 infections with such antibiotic-resistant bacteria. That resulted in more than 35,000 deaths that were directly attributable to these infections. More than 1 million years of life, or so-called disability-adjusted life years, or DALYs, were lost because of premature death or years lived with disabilities. And 70% of this burden is linked to healthcare-associated infections. There are, of course, differences between countries. For example, after having control for the population, there's somewhere between 10 times to 12 times a higher burden in some of the EU member states. Between 2016 to 2020, the burden of antimicrobial resistance in the EU, Iceland, and Norway increased, but the increase has been relatively small from one year to the next. Today, ECDC is also publishing 2 reports with updates on it with the 2021 data, one on antimicrobial consumption from the European Surveillance of Antimicrobial Consumption, or ESACnet network, and one on antimicrobial surveillance from the European Antimicrobial Resistance Surveillance Network, EARSnet. These reports confirm the large differences in antimicrobial consumption and in antimicrobial resistant percentage between the countries, with usually much higher antimicrobial consumption and much higher antimicrobial resistant percentages in countries in the south and the east of Europe than in countries in the north of Europe. Both reports as well as corresponding electronic databases, are accessible from the ECDC website. For antimicrobial resistance, our surveillance data showed an increase in the EU, Iceland, and Norway between 2011 and 2019 for most of the pathogens that are reported to EARSnet, but this changed in 2020. During 2020 and 2021, there was a decrease in the number of infections for some resistant pathogens, but an increase for other pathogens. The resistant pathogens that showed a decrease were usually those responsible for community infections, such as antibiotic-resistant Streptococcus pneumoniae. There was also a decrease for methicillin-resistant Staphylococcus aureus, MRSA, or third-generation cephalosporin-resistant E. coli in 2020-2021. Inversely, there has been an increase in the number of infections for resistant pathogens that are usually responsible for healthcare-associated infections, mainly in intensive care units, and in particular, vancomycin-resistant Enterococcus faecium, VRE, carbapenem-resistant Klebsiella pneumoniae, and carbapenem-resistant Acinetobacter. Finally, as Dr. Ammon mentioned previously, two pathogens showed a very large increase in the number of cases in 2020 and even further in 2021, namely carbapenem-resistant Acinetobacter and Candida auris, a fungal can be resistant to multiple antifungal agents. ECDC conducted specific analysis for these two pathogens, and the results will be published in Eurosurveillance this afternoon. For carbapenem-resistant Acinetobacter, the increase was seen mostly in intensive care units and in those EU countries that already had a high proportion of carbapenem-resistant Acinetobacter bloodstream infections before the COVID pandemic. For Candida auris, an ECDC survey showed that the number of cases first increased in 2020, then sharply increased further in 2021. Both pathogens are known to produce outbreaks and are difficult to eradicate while established in a healthcare setting. And their control in a country is difficult to achieve once dissemination has reached the level of inter-facility and inter-regional spread. In this context, rapid control of local outbreaks has a nationwide benefit. ECDC has produced several rapid assessments that review the options for response and for the prevention and control of the spread of these pathogens in healthcare. These options for response include adequate laboratory capacity and national surveillance for early detection of cases and rapid implementation of control measures, such as alerts to healthcare staff, screening of patients for carriage, contact tracing, and enhanced infection and prevention control measures. This year, we're one day ahead. Tomorrow, 18th of November, we will be celebrating our 15th European Antibiotic Awareness Day, a European health initiative that we started to raise awareness about prudent use of antibiotics and more generally about antimicrobial resistance. 18th of November also marks the first day of the World Antimicrobial Awareness Week. A lot has been accomplished since the first edition of European Antibiotic Awareness Day in 2008. For example, antimicrobial consumption in humans has gradually been decreasing. Successes have also been achieved in many EU member states and other sectors in a One Health perspective, and these will be reported at our European Antibiotic Awareness Day event this afternoon. The data reported by ECDC, however, show that we should not stop our efforts. MR is not the next pandemic, it's already here. As a slow and silent pandemic, with each year a small increase in the number of infections, attributable death, and life years lost to antimicrobial in EU, Iceland, and Norway. In addition, the first 2 years of the COVID-19 pandemic have shown large increases for some of the antimicrobial resistant pathogens that are difficult to eradicate. To echo what Dr. Ammon mentioned, we must not lower our guard. We need to promptly identify outbreaks as well as continue building capacity for implementation of use of whole genome sequencing, in particular for carbapenem-resistant bacteria. We also need to continue improving infection prevention control practices in hospitals and other healthcare settings, while at the same time continue our efforts to reduce unnecessary antimicrobial use. Thank you.
Thank you, Dominique. I now open the floor for your questions, and we already have first set of questions. So I go to Maxi Eckert, the Standard. So please, Maxi, go ahead and ask your question.
Yeah, thank you for taking my question. So I was wondering if the increase of the consumption of broad-spectrum antibiotics in healthcare settings and the increase of outbreaks in healthcare settings can be linked to the COVID pandemic, because a lot of COVID patients were given, hospitalized COVID patients were given antibiotics to prevent bacterial infections. So do you see that link?
Thank you for your question. I think, Dominique, this would be a question for you.
It's the most plausible hypothesis, but we do not have the link at the level where we would like to have it. That is, for example, in intensive care unit, it is obvious that in intensive care units, there have been an increased use of carbapenems, and also in hospitals. And we see an increase in carbapenem resistance. So there's a logic association, but we did not test this with our data so far. To note, there have been a decrease in MRSA and in third-generation cephalosporin-resistant E. coli. And we see this as a decrease happening not in intensive care units, but in other wards, in hospitals in the EU. And we believe that this is an effect on patients on surgical interventions that were postponed. So antibiotics for prophylaxis were not prescribed, and there were no healthcare-associated infections related to those. So we need to be careful before linking one to the other, because, as I mentioned, contextual decrease in some parts of the hospital and increase in other parts of the hospital.
Thank you, Dominique. And now we have questions from Sarah Newey from Telegraph, and I will read it to you because you have placed it in the chat. So these figures seem lower than the Lancet study at the start of the year, which estimated 1.2 million deaths worldwide, including 51,000 in Western Europe. Why is this? It has been said deaths are rising. What are the previous figures of fatalities and infections across ECDC countries? How has it changed? Dominique, please.
Yeah, first, the discrepancy between the figures from WHO. WHO has been considering, the figures, the broad figures that were developed by IHME and that were used for WHO to produce its estimate. Consider Europe, a larger Europe, like the WHO European region, while we just consider the EU member states, Iceland and Norway. So it's much smaller for this reason. Second, we're using different methods. In particular, the method used by HME and for the European region by WHO is considering all those deaths that are associated with an infection. In the way I understand it's been done, there's no effort being made to find out whether the infection was the cause of death or whether death was related to something else. It's just that in a patient file, there was a record of a death and a record of an infection. So that's another explanation for the difference. Has it changed in the EU? Our previous estimates were 33,000 attributable death, and that was in 2015. And in the meantime, we had to not consider the UK as part of our estimates. And there have been just a small increase, like I said, from year to year since 2016 to 2019 and a small decrease in 2020. There were obviously less cases and there were less attributable death and less deaths. I hope I replied to your question.
Thank you, Dominique. Questions here. First, I'll go to Angelo Di Mambro from ANSA, and that's question for our director. Andrea, please. Angelo, please.
Yes. Thanks. Thanks for the briefing, Angelo Di Mambro for ANSA, Italian news agency. To Andrea Emon, okay, there are infection and deaths and DALI, sorry, are increasing, but there is a stark difference among the member states. We have, for instance, 19 or 20 deaths for 100,000 inhabitants in Greece and in Italy, and 2 in the Netherlands. So I was wondering if you could elaborate a bit further on the reasons why the southern eastern countries of Europe have a higher health burden from AMR.
Yeah, thank you. That is a pattern that we observe basically since the beginning when we looked at antimicrobial resistance in the EU. This pattern that in the north there are fewer and in the south there are more. We believe that is mainly related to different practices, but we have to also acknowledge also in the south of Europe, there are hospitals and healthcare settings that have quite low antimicrobial resistance, and also there are healthcare settings in the north that have higher than the average. So it is really looking at the hospital level to look at the practices, and this is why our country visits are so useful, because there this can be reviewed and addressed. I don't know, Dominic, whether you would like to add.
Well, maybe add some data. As part of a joint work from ECDC and OECD, there was a joint briefing note that was produced in March 2019, in which we tried to sort it out. And we produce 4 correlations, tried to explain why we had more resistance in some countries and less resistant, with a focus on acute care hospitals. So the index of antimicrobial resistance that we had was positively correlated with the percentage of patients that received antibiotics, not surprising. Closely correlated by the percentage of prescriptions of antibiotics that had been reviewed. And for infection control was inversely correlated by the percentage of beds in the hospitals that had availability of an alcohol hand rub bottle at bedside, and was inversely correlated by the percentage of beds in single rooms, rooms that were available for isolated patients. So to summarize all these factors were independently in a model related to the antimicrobial resistance. So the more antibiotic use, the more resistance. The more antimicrobial stewardship, the less resistance. The more infection control structures and processes and resources, the less antimicrobial resistance. Again, this is in a joint summary, a joint briefing note from ECDC and OECD from March 2019.
Thank you, Dominique.
Thank you.
We have a follow-up question to Angelo's question. So, Stefan, please, apologies, but we noticed that you had hand up, but please let's allow for a follow-up question from Isa Corona, Swedish broadcast. Isa, go ahead.
Yes, from Sweden, I have follow-up on that subject. To Andrea Mond. You mentioned that there were fewer cases in northern Sweden and connected it with the practices in the hospitals. Could you specify what are hospitals in the northern countries doing better? Do you have any measurable data? What's been doing right?
Yeah, as Dominic just explained, what we are looking at here is the overall use in the hospitals. This is also where our point prevalence service will give information, which the prescription, and then the infection prevention and control. So these are the largely the indicators that we look at. Sometimes it's also the availability of specifically trained staff per beds. And I didn't mention the north of Sweden. I mentioned the north of Europe in general. So it's more the region within the EU that we compare.
Yeah, thank you very much.
Thank you, Andrea. Thank you, Isaac, for question. So now finally we go to Stefan Trumpf, DPA. So Stefan, please, you can ask your question. I saw you have two, so please go ahead.
Okay, thank you very much. And thanks also for the report. Like one question is rather technical, the other one is about awareness. First, how come that the little country of Liechtenstein is not included in the report, just out of curiosity? And speaking about awareness, what can be done to raise the awareness among the public for a more careful use of antibiotics?
Yeah, maybe I go for the awareness and leave the Liechtenstein question to Dominic. So for the awareness, I mean, one of the things that is part of this awareness day since actually 2008 is to raise the awareness. You maybe have seen that we have produced some debunking, myth debunkings videos on what antibiotics should not used for, or how they should be used, because that is the point now for the particular, because we have to raise the awareness of everybody, but in different ways. So for the patients, it's more that they have to be clear they cannot take their old antibiotics, they cannot use antibiotics for viral infections, and they have to take them as prescribed. Now, for the doctors, it's more that they have to advise the patients really how they should be taken. They should also look first at smaller spectrum, if possible, do a testing, antimicrobial sensitivity testing, and then it's for the hospitals for the infection prevention and control. So there's a whole load of different groups that need different awareness campaigns. And that is tested how the awareness is developing for the general population. The Commission does this with the Eurobarometer service, and there is a new one coming out, I think today or tomorrow. And we have done a survey on knowledge about antimicrobial use and antimicrobial resistance among healthcare professionals. I think it was also 2019. And maybe Dominic can also explain the findings there from there.
Yeah, so there's a wealth of resources. We started in 2008. So if you go on the European Antibiotic Awareness Day website, you will see materials that address the general public, key messages that have been translated in all EU languages, official languages, that address also the general practitioners, the hospital practitioners, and videos and animations that have also been developed to support the countries in doing their job. There was no Eurobarometer for healthcare professionals, so we did one survey, one shot, just before the COVID pandemic hit us. It's, I mean, there was some participation, but participation is not complete, and we'll need to redo such surveys to see exactly what is the level of awareness. The level of awareness among doctors is, of course, and healthcare professionals in general, is much higher than that of the general public. And the Eurobarometer from the European Commission shows that the public, people, trust their doctor for advice. So we need to make sure that the doctors know exactly about antibiotic and know what they're doing. Liechtenstein. So I'm happy to announce that Liechtenstein has now nominated national focal points for all the diseases and the special health issues that for which we're coordinating surveillance at ECDC, and that includes antimicrobial resistance, antimicrobial consumption, and healthcare-associated infections. So I know that there are already technical discussions between colleagues in Liechtenstein and colleagues responsible for surveillance here at the CDC. So I believe next year, or if not in the coming years, there will be data from Liechtenstein as part of our reports.
Thank you, Dominique. I have another question from Maggie Fick from Reuters, so I will read it now. There are actually two questions. I believe first one is for you, Dominique. So the release refers to the years 2016-2020, but also mentions data on cases from 2020 and 2021. Can the ECDC give any data on deaths for 2020 and 2021?
Of our surveillance data, and I would say these reports are the report that are produced with the fastest turnover at ECDC. And we just had some confirmation of the data the past weeks. So we first consolidate our surveillance data, and we did this for 2021. We're happy to release them today. And then we'll work at estimating the burden for 2021. My guess is because the burden, the number of attributable deaths, the number of disability adjusted life years, really depends on the number of infections. We will see another small increase in the burden in 2021. But this is just a guess. We'll have the results in the coming month.
Thank you, Dominique. And second question, I would refer to you, Andrea. Has the COVID-19 pandemic made the already severe problem of drug-resistant bacteria much worse? And if so, how?
Yeah, as we have highlighted, there are some areas where the trends are a bit better, and some areas where the resistance has increased. Now, for me, the biggest issue was that AMR as a public health challenge and issue disappeared in the back. Given the whole effort that was devoted to COVID. So we have now to make an effort to bring it at the forefront again, and to start where we have stopped in 2019, and to see whether the decreases that we observe can be kept and the increases can be lowered.
Thank you, Andrea. I hope, Maggie, this answers your questions. And for a moment, I don't see any other in the chat, but if you still have any questions, please feel free to ask. If this is it, then I will thank you for your attention. Thank you for your participation. And if you have any questions whatsoever, you can write to us in our press email. Also, I would like to use this opportunity to announce another press conference we will have on 30th of November, and with the topic of AIDS. Until then, we send greetings from Stockholm, and stay healthy.